Hello everyone, welcome to Medics Corner. Today we're going to be discussing pulmonary embolism. What is a pulmonary embolism, or a PE? It is an occlusion of the pulmonary artery or one of its branches. About 80% of the cases are due to a blood clot. Fat emboli, air emboli, or a tumor may also cause a PE. It is closely related to VTE, short for venous thromboembolic disease. Venous thromboembolism includes PE and a DVT, short for deep vein thrombosis, where the deep veins are occluded by a blood clot, usually in the lower extremities. The clot is formed in the lower extremities and breaks into an embolus. The embolus then travels to the right side of the heart via the venous system, eventually reaching the pulmonary circulation, where it causes a PE. This results in ventilation-perfusion mismatch, which can result in an array of symptoms, some of which we will discuss later. When looking at the pathophysiology of a PE, think of virtuous triad, which comprises three main factors or components that promote the formation of blood clots. The first component is hypercoagulability, which happens when a patient has a disorder that makes formation of blood clots more likely, such as antiphospholipid syndrome. The second factor is endothelial injury, which induces thrombosis. Lastly, we have venous stasis, where slowed venous circulation makes it easy for clotting factors to aggregate, forming a thrombus. Classification of a PE. Classification by timing. The PE can be acute, presenting at the onset of the occlusion, or it can be subacute, presenting within days or weeks of the occlusion. It can also be chronic, where the PE presents with complications of pulmonary hypertension. We can classify a PE by location in the lungs. The PE can be segmental, occurring in one of the 10 segments of the lungs, or it can be lobar, occurring in one of the lung lobes. It can also be a saddle PE, where the occlusion is at the bifurcation of the pulmonary arteries. Classification of PE by severity. It can be non-massive, where patients will be hemodynamically stable with no signs of right heart strain. It may be submassive, where patients are hemodynamically stable but show signs of right heart strain on imaging, such as right ventricular hypertrophy on echo, with raised troponins. Some patients may present with massive PE with signs of hemodynamic instability, such as blood pressure of less than 90 mm of mercury or a fall of blood pressure to 40 mm of mercury. Now we are going to look at risk factors for PE. Major risk factors include DVT, VTE history, active cancer, surgery in the past 2 to 3 months, significant immobility such as with wheelchair users, lower limb trauma such as fractures, and pregnancy. Other risk factors include combined oral contraceptive pill, long-haul flights, thrombophilia, and obesity. Let's look at features of a pulmonary embolism. Symptoms include coughing, with or without hemoptysis, syncope, shortness of breath, pleuritic chest pain, leg pain and swelling. Signs of a PE comprise an increased heart rate of more than 100 beats per minute, low-grade fever of about 37 degrees Celsius, and a low oxygen saturation of less than 94%. Patients with a PE present with features of right-sided heart failure, including hypotension, raised JVP, and tricuspid regurgitation, which is heard as a pansystolic murmur. In addition, pulmonary hypertension results in the split of the second heart sound, as increased pulmonary pressure delays pulmonary valve closure. Investigations for a suspected PE. Usually, the first step in the assessment would be a 2-level PE Wells score, where a score of greater or equal to 4 indicates a likelihood that the patient has a PE. The criteria used to calculate the Wells score is provided in the NICE guidelines. If a PE is highly likely, then a computer tomography pulmonary angiogram (CTPA) may be ordered, or a ventilation perfusion scan may be carried out if a CTPA is contraindicated. Note that a CTPA is the gold standard investigation. If a Wells score is less than 4, then a PE is unlikely, but if suspicious, then a D-dimer can be checked. And if this is low, then a PE is still unlikely. Note that a raised D-dimer cannot be used to diagnose a PE due to low specificity. There is a high probability of false positive results. If the likelihood of a PE is low, then the NICE guidance recommends using the pulmonary embolism rule-out criteria, PEG. PEG is used to determine the need for further investigations, and a score of greater or equal to 1 means a PE cannot be ruled out. The role of chest X-rays for patients suspected with a PE is to rule out other causes of symptoms, such as pneumonia or pneumothorax. Note that chest x-rays are neither sensitive nor specific for a PE. Please watch out for part 2 on this topic, where we will discuss treatment of patients with pulmonary embolism. Please like and subscribe to my channel. Thank you for watching Medics Corner.